first of all, I just said with the previous question that sometimes randomized controlled trials come up with a surprise. For me personally, SwiftDirect came up with a huge surprise. Basically, SwiftDirect was randomizing into two arms. One is the bridging thrombolytic arm, probably what we have learned from 2014 trials, compared to direct mechanical thrombectomy in large vessel occlusion and circulation. And the background of the trial was that we haven't seen lots of recanalizations in mothership patients by applying IV thrombolytics when the patient comes to the angio. So what is it worth if you don't see recanalizations? And in fact, that's what we see again in the pre-interventional recanalization rate in the bridging arm. This is very low. So IV thrombolytics does not do what it's supposed to do. It doesn't recanalize. But then the surprise is that the recanalization rate, if you look at the Tiki scores, the recanalization rate with the bridging arm is much higher, which actually converts in very good clinical outcome in the bridging arms, not superior, but definitely we can't prove non-inferiority of the direct mechanical thrombectomy arm. So the surprise is there is a working principle, what we haven't looked at or we haven't understood so far around mechanical thrombectomy. So in the peri-procedural pattern phase of thrombectomy, IV thrombolytics seems to be effective. So this is what we have seen, which is not in line with previous randomized controlled trials, especially from the Asian population. Well, one question will be the triage of patients that hasn't been addressed by SwiftDirect, but by RaceCat. So how much detour do we want to allow for IV thrombolytics instead of going directly to mechanical thrombectomy? If it comes to mechanical thrombectomy, I think there's a lot to clarify still. I wouldn't say it's everyone does what it wants to do in the angio, but there's no clear pattern. So if you have a carotid T occlusion, what kind of devices do you use? And I think in the recent trials that we looked at on bridging versus direct mechanical thrombectomy, so many different approaches have been used. So I think the pooled analysis of these studies will elucidate what kind of procedure and what kind of device is the most successful one to reopen a certain occlusion pattern. I think there's lots of re-improvement. Clinical science is always about finding room for improvement, of clinical improvement. And from my point of view, even for the large vessel occlusion in the anterior circulation, there is lots of room for improvement to define which occlusion pattern requires which approach. And then, we still have the huge black box of the posterior circulation, which has not been proven to be effective for mechanical thrombectomy yet, although everything points to this direction.